time is brain, so you have to act fast.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere.
Approximately 1.9 million neurons die during just 1 minute of having had a stroke. So time really matters. More treatment options are available. The faster you are in the hospital, the faster we can intervene, the better.
You've just heard Dr. Mira Katan, Head of Stroke Unit and Deputy Head of Acute Neurology at University Hospital Basel in Switzerland. Here, she explains why timing is so incredibly crucial for a stroke patient's positive prognosis. In this episode, Wiebke Plenkers, Product Line Head for Siemens Healthineers On the Spot Global Point of Care of CT Solutions, is joined by Dr. Mira Katan and Dr. Carlos Molina, Head of Neurology and Director of Stroke Unit at Barcelona's Vall Research Institute.
Hello, my name is Wiebke Plenkers. Every year, more than 12 million people suffer from a stroke. With 6.5 million dead and many left with permanent disability, it is one of the leading causes of death and disability worldwide. The stroke pathway refers to the treatment plan for individuals who have suffered from a stroke. Both reducing the impact of the stroke and preventing a secondary stroke are top priority for healthcare practitioners. This is done through precise diagnosis and guidance to get as many stroke patients to the right treatment as fast and efficiently as possible. Today, we learn about the stroke pathway and secondary stroke risks, as well as the underlying diseases that are connected to stroke and how they can be identified and treated.
When the patient has a stroke in the street or at home, and then the paramedics, the ER, the EMS system recognize the stroke, or even the family surrounding the patient recognize the symptoms and activate what we call the stroke code. This is essential to transfer the patient as soon as possible to the hospital. Then, once the patient arrives to the hospital and the CT scan is done to differentiate between ischemic stroke or hemorrhagic stroke. And then we have different pathways of care depending on the stroke severity or the type of the stroke. We have specific treatments. Then the patient is admitted in a stroke unit where general care is conducted, so the patient is stabilized there and the source of stroke is identified with a more advanced diagnosis.
That was Dr. Carlos Molina, Head of the Stroke Research at Vall Research Institute in Barcelona, detailing the ideal procedure pathway for an incoming patient after it is determined that they are suffering from stroke. But stroke diagnosis can begin even before a patient seeks medical attention. According to Dr. Mira Katan at University Hospital Basel, identifying the typical symptoms of an acute stroke as fast as possible is an integral indicator of survival.
There is actually a very good acronym, FAST. F stands for face dropping, A stands for arm weakness, S stands for speech difficulty, and T, time to call the emergency. Time is brain, and we have to really do things fast. And these are some of the hints for the lay public not being in healthcare profession to probably be easy to memorize. And it refers to some of the symptoms which are common if you have a stroke. If you can't move your arm and your facial drop on your right side, for example, and also can't move your leg, that would be a one-sided weakness suddenly happening. This is a typical sign of a stroke, but it can also include speech disturbances. So you can probably not really speak clearly, or you can't understand what someone tries to tell you.
After a patient seeks medical attention, hospitals like Vall determine the type and severity of the stroke, as it is the most important deciding factor for successful treatment.
A minor stroke means those who have a minor neurological deficit, but still at risk of recurrent stroke. We have a specific pathway. For moderate and severe stroke, we need a different pathway, including rehabilitation, including admission and the stroke unit to avoid complications.
Typically, patients stay 5 to 6 days in the hospital before being discharged, whether that means going home to a rehabilitation facility or, in more severe cases, a nursing home. Unlike other serious illnesses such as cancer, the treatment pathway for a stroke is typically very straightforward, but is also extremely time-critical and decided shortly after admittance. In Barcelona, Carlos Molina and his team have identified a series of key performance indicators, or KPIs, that are crucial to successful patient care, including injection of the medication TPA, which dissolves stroke-causing clots. Another treatment option, endovascular mechanical thrombectomy, is a minimally invasive mechanical removal of the blood clot. It exists for severe strokes called large vessel occlusions, or LVO.
The main driver to improve the quality of care is having KPIs and track them. Door-to-needle time is the time for patient arrive to the hospital till the treatment is initiated. Door-to-growing time is another critical KPI. This is for mechanical thrombectomy. It means the time from patient arrival to the hospital till we start the endovascular treatment. Typically, door-to-needle time has to be below 30 minutes in Europe. This is what is established. The sooner the better.
For Mira Katan, the most integral factor for successful treatment is determining the nature of stroke that the patient has suffered.
There are different subtypes of stroke, 80% more or less, depending on the racial ethnicity and so forth, is ischemic, meaning that a vessel within the brain is blocked, or a vessel which contributes to the perfusion in the brain is blocked. Then you also have hemorrhagic stroke, meaning that a vessel in the brain ruptures and bleeds into the brain.
And thanks to modern imaging techniques, making that identification between an ischemic and hemorrhagic stroke is typically quite straightforward.
The gold standard is an imaging procedure, a CT scan we do, and we in Basel do a CT angio, so we also look at the vessels at the same time. And depending on some other information, we also do perfusion imaging. Then we evaluate, is it an ischemic stroke or an hemorrhagic stroke? And that's obviously not too complicated for some experienced people to see. These are the first big categories of stroke. But if you go more down in the hierarchy, you have underlying etiologies of ischemic stroke, so things which causes an ischemic stroke, a blockage of a vessel, and other things which cause a rupture of a vessel. And some of these risk factors are in common and some are different.
After diagnosis is made, physicians then decide on an acute treatment path.
If it's an ischemic stroke, they look different than when it is a hemorrhagic stroke. Within the ischemic strokes, there is differences also depending on size of the stroke, how old or when it had happened in time, many different questions. That's why it's important it has to be a team, because many things have to be done in parallel and at the same time, trying to be as fast as possible.
Of course, there are also times when a patient presents with stroke-like symptoms, yet imaging identifies another cause altogether.
We call them stroke mimics. They clinically look very similar, but then there are different diseases. And of course, to treat the stroke, you have to first get the diagnosis of a stroke straight. Similar clinical symptoms can, for example, also occur with the brain tumor. Brain tumors usually do not develop over milliseconds. They're usually not as sudden, but they can be. And that's something you can also differentiate by doing an image. With infections, it's a bit more difficult. Lab results are really important, but also some clinical signs which can hint towards the one or the other. And all of this is important to distinguish because you treat them obviously differently.
Though there is relief once a stroke is identified and a treatment path is put into place, many stroke patients often face an unfortunate reality, a significant risk of a secondary occurrence. Timely treatment with proper medication or endovascular therapy is absolutely essential, The faster the treatment, the better the chances for a good patient outcome.
If someone had a stroke, there is unfortunately quite a risk that the same person suffers from another stroke. What we're trying to do in secondary prevention is to prevent exactly that from happening. Unfortunately, the numbers are still quite high. 10 to 20% of patients who suffered from a stroke will suffer from another stroke within about 5 years.
For Carlos Molina, there is no time to waste when it comes to being proactive on the matter.
Secondary stroke prevention starts the next day after a stroke. So it is as soon as possible because early recurrence occurs, especially in patients with TIA and minor strokes that look like it's not that severe. They have a high risk of early recurring stroke. In some cases, can be 60% risk within the first week.
For secondary stroke prevention, one indispensable tool that healthcare providers have is the power to educate their patients. Unfortunately, ensuring that a prevention plan is followed is also one of the most difficult aspects of treating a stroke patient.
The problem with the stroke is it's like having an accident, a car accident. You want to forget that. This is a part of my life that needs just to erase from my mind. This is typical human behavior. So months after stroke, they just quit the medication because they feel, okay, I'm okay. But they don't know they have a ticking bomb inside. They don't take the medication, it will occur again. So the long-term risk of recurrence persists. Most secondary prevention strategies fail because of lack of treatment adherence. And that's critical. That's why we need to use technology and humanity in a good balance to just accompany the patients and coaching them.
To help curb this issue, providers at Vall have developed a program designed specifically to follow up with stroke patients and encourage adherence to their specially designed course of treatment.
Education is critical. We have education we develop in our hospital, educational platforms and patient follow-up platforms to ensure treatment adherence and also avoid readmissions. We developed this platform to integrate all the data. We have a case manager. It's behind the application. It's not just digital application. We need to customize the way the patient is follow up. So the staff use this platform to connect to the patient. So we have video calls with the patient once the patient is transferred home. So he's home and the patient is at home and can connect to the physicians anytime they have questions or problem with the medication. They feel more supported. This transition to post-hospital care is essential. We don't want the patient to suffer a second stroke or a third stroke. Actually, 1/4 of patients have a recurrent stroke. So we need to avoid this situation by very comprehensive secondary stroke prevention.
In both Barcelona, Spain and Basel, Switzerland, doctors treating stroke patients follow two main pillars of secondary prevention.
Treating risk factors, one pillar, and the other pillar is treating or identifying the most likely underlying cause because they're treated a bit differently. But risk factors are shared by almost all the strokes. So risk factor treatment we do in everybody who has a risk factor, independent of their underlying cause of the stroke.
Those risk factors, once identified, can include everything from hypertension to diabetes to pre-existing conditions of the heart.
Hypertension is a risk factor, for example. You treat hypertension, but you treat hypertension in a patient who has a cardiomyopathic stroke as you do as a patient who has a large vessel stroke, for example. If we identify that this is, for example, a large vessel stroke, and you have a carotid stenosis, in this case, you would treat all the risk factors of the patient, so should stop smoking, blood pressure, diabetes, his lipids should be properly treated, but the stenosis per se should be treated as well.
Atrial fibrillation is the first cause of stroke due to cardioembolism, so it can be detectable just by checking our pulse. If we check regularly every day, like, how is my pulse? Is regular or irregular? So if it's irregular, we need to perform an ECG just to take if you are suffering an atrial fibrillation, if you have palpitations, you have to consult the general practitioner just to exclude that you have an atrial fibrillation. This is the main cause of cardioembolic stroke, especially in women.
It's also important to note that, according to Carlos Molina, these risk factors don't exist in individual vacuums.
There is an accumulation of these risk factors. So it's not just being diabetic or not diabetic. It's for how long the diabetes is hitting your body, your brain, all the organs of the body. So that's why it's important that age plays a role. The older you are and you are not controlling this risk factor, this accumulation, the impact of risk factor and the combination of risk factor play a role in increasing the risk of a stroke. That's why stroke is also more frequent in older patients.
And although secondary stroke can occur through the same mechanism as the first, that's not always the case.
So it's really important that you look for all kinds of underlying potential diseases which can cause a stroke. Because if you had a stroke due to, for example, a carotid stenosis or a diseased artery which helps to perfuse the brain, doesn't mean that that will be the one causing the second stroke as well. It could be that you have at the same time an underlying heart disease and your future stroke comes from that underlying heart disease. So you have to really do a very thorough workup in order to have a full picture of that patient and to be able to prevent another stroke for exactly that patient, because that picture is very individual, obviously.
While secondary risk remains a very real hurdle for stroke patients to maneuver, there are also excellent tools currently in use to help understand underlying causes and mitigate that risk. CT, MRI, and ultrasound are all employed in this manner and may be used to create images that help with everything from showing blood clots in the heart to providing insights on carotid plaques. When considering the future of stroke prevention, diagnosis, and treatment, both doctors are enthusiastic to see the potential of emerging technology realized.
What would be really interesting actually would be to have more sophisticated methods able to monitor risk factors, one pillar, and underlying potential mechanisms, diseases, all in real time. Because each factor contributing to the risk of stroke may also change over time.
For Mira Katan, much of the potential involves mitigating risk factors for patients vulnerable to secondary strokes.
What is difficult to estimate is how compliant patients are, because they think, oh, I feel well. No, I don't. I think my blood pressure is perfect again. I don't need that drug, and so forth. We see that a lot happening. If you had some way of real time measuring all these things and then giving feedback to us as experts, and we could give feedback to the patient, that would be something really new and really would change the game.
In Spain, Carlos Molina looks forward to a future with wider implementation of techniques that will make medical response times even timelier.
It's important to establish a rapid access telemedicine, to deploy a telemedicine system at a regional level to capture those patients, also improve the diagnosis of those patients who are going to benefit, for instance, mechanical thrombectomy. So having mobile stroke units in the field will dramatically change the scenario, because we will have CT scans and remotely connected staff that can take decisions in the field minutes after symptom onset, and it will improve both diagnosis and accessibility to treatments. This is the way how we accelerate the treatments, and once the patient is initially diagnosed and treated, can be directly transferred to the angio suite. So we skip all the bottlenecks of the ER. We go straight to the angio suite. This door to needle time will be few minutes. This door to groin time will be less than 15 minutes instead of 45.
While a mobile stroke unit can start treatment of patients in a fraction of the time of an ER response, seems like something from the future, it's already happening with great success in several cities around the world.
The mobile stroke unit concept has been tested in different scenarios, in different areas, like in in the US, in Texas, in Australia, and also in Germany. It has clearly demonstrated to be cost-effective and also to improve patient outcomes, especially in Germany, in the area of Berlin. They have a very comprehensive studies demonstrating clearly that the implementation of mobile stroke units shortened the treatment time from hours to minutes.
Today, we've heard from doctors Carlos Molina and Mira Katan about a number of important factors that go into both the treatment and prevention of stroke, including the incredible importance of avoiding a secondary stroke. Hospitals around the world work hard to offer stroke treatment as fast as possible. With advanced imaging technology, they are able to accurately detect the underlying cause of stroke, and by focusing on aftercare, they can also reduce the possibility of a secondary stroke. As Carlos Molina points out, these advances in stroke care are needed more than ever.
Stroke is the major cause of death and severe disability worldwide. It's the first cause of death in women in Europe. With the aging of the population, the proportion of stroke will double for 2030 because of the aging of the population. So this is important. I think any change in the prevention, any change in the acute treatment will dramatically impact the health of people in the future. We need to implement strategies to optimize primary stroke prevention. It means avoid first ever stroke. This is the next frontier.
You've been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed, or visit siemens-healthineers.com/podcast for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers in this podcast are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory, and many variables exist, for example, hospital size, samples mix, case mix, level of IT, and/or automation adoption, there can be no guarantee that other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.